Good evening. I think we'll go ahead and get started. I'm sure people will be coming in. We'll blame it on the sunshine. That's why people are late. Good evening. My name is Kelsey Priest. I'm an MPH Health Management and Policy student here at Portland State University. And I'm also the chapter president of the PSU and OHSU IHI Open School Chapter. And on behalf of the chapter and We Can Do Better, I want to welcome you to our event tonight. We are so excited to have both Dr. John Santa and Ms. Liz Baxter with us, and I'd like to give them a warm welcome. I would also like to thank our sponsors of this event, the Marco Hatfield School of Government Division of Public Administration, and We Can Do Better for their support. We really, really appreciate it. As you know, you can't have events without sponsors, so thank you again. Really appreciate it. Okay, so before we get started, I would like to briefly tell you about the IHI. The IHI is a nonprofit organization based out of Cambridge, Massachusetts. It is international in scope. The IHI aims to improve the health for patients and populations through developing the will for change, the development of programs and initiatives, and then the execution of those programs and initiatives. So the Open School is actually one of those programs. It was launched in 2008, and it aims to improve the health for patients and populations through filling an educational void that healthcare professional students they observed were currently lacking. So there's curriculum content, there's community networks, and experiential learning. Our chapter is one of 550 chapters worldwide with over 120,000 students enrolled at the IHI. And I also spoke about the online curricula that is free for students and faculty. And there's courses on leadership, management, quality improvement, patient safety, just to name a few. So that's kind of the big picture. So what does our local chapter do? We aim to bring together healthcare professionals, students, and faculty from across the Portland metro area, all in the service of developing skills and quality improvement and patient safety to really make a difference in our community. So with all of that in mind, I would now like to introduce John Santa and say a few words about him. John Santa is the director of the Consumer Reports Health Rating Center. The Rating Center focuses on explicit approaches evaluating and comparing health services, products, institutions, and practitioners. Dr. Santa has previously worked in leadership positions for hospitals, physician groups, and health insurers. He was the administrator of the Office of Oregon Health Policy and Research from 2000 to 2003. During this time, he helped organize and implement an evidence-based approach to prescription drug purchasing that eventually came to be known as the Drug Effectiveness Review Project, also known as DERP. He practiced primary care internal medicine in several settings, most recently at the Portland, Oregon VA. And finally, he is an alumnus of the MPH Health Management and Policy track here at Portland State University in 2005. Thank you so much for being here.
Well, it's really terrific to be here. I come mostly because of a reunion of my internship and residency classmates. In 1976, I came here to be an intern and then a resident at Good Samaritan Hospital. And as you've just heard, was here until 2008, when my wife and I moved to Yonkers so that I could work at Consumer Reports, and she could work at a progressive school called the Bank Street School in the Upper West Side of Manhattan. She's a real New Yorker. She goes by train and subway, hour each way. I drive a car 1 mile in a suburban setting to Consumer Reports, which is in a business park, and in Westchester County. Very, very nice place to work. Well, what I'm going to do in the next 40 minutes or so is take you through the key work we're doing, which is, we do comparisons. That's what we do. And this is really our time because there's so many wonderful things happening around comparisons. Wonderful for us. Some of this, I think, is going to be upsetting. It's going to be challenging. I hope it's stimulating because there are some things here that we would like to do in Oregon. Certainly hearing that there's folks here in the IHI school who are interested in safety is good news for us. Because as you'll see, we think this is one of the most important, and I'm sad to say, fatal problems in today's healthcare system. So it's great to be here. So the next few slides are about disclosing. This is a big deal for us. We think this is really important. We think it's important that we do it. We think it's important that everybody does it. And these days, when I see healthcare talks, I always note whether the speaker has disclosed or not, and then how comfortable they are with disclosure. I mean, oftentimes what speakers will say is, oh, well, here's the disclosure side. I was required to do that. I'm not quite sure why. And next slide. Because at Consumer Reports, we think comparisons start with being trusted, being credible, being independent. And we know from our surveys and focus groups that consumers are making that decision right on the front end. Is this worthwhile reading or listening to? They're looking for signs of trustworthiness or untrustworthiness, independence or dependence right from the start. So I'm employed by Consumer Reports. We are very proud of the fact that we are independent of industry. We're a nonprofit. We're nonpartisan. We are not unbiased. We advocate for consumers. We are biased in favor of consumers. We are a very powerful multimedia company. Consumer Reports has a revenue stream of about $250 million. 10 million comes from donations, a few million from grants. So we are funded by individuals like you all who subscribe. It's a very powerful business model. It enables us to be independent in a variety of ways. And we have a variety of rules that keep us independent. For example, I never accept any honorariums. I oftentimes, except in unusual circumstances, my expenses are paid by Consumer Reports if I go to any organization that we rate or we compare. We have a very interesting audience. 20 million people read our materials a month one way or another. They're older, they're affluent, they're well educated, they're savvy buyers, they're predominantly white, they're overwhelmingly white. So we don't have a nationally representative sample. But we've gotten very good at communicating with those 20 million people. We really know our stuff. The last couple of weeks have been terrific weeks for us. I won't go into it in detail, but in March of this year, the March edition of Consumer Reports, we had a story about cancer screening tests. Okay? We got the cover. The cover was 3 tests that will save your life and 8 tests that don't, that are a waste of time. We got 6 pages in the magazine. We basically told the same story that the U.S. Preventive Services Task Force tried to tell 2 years ago. Okay? We do readership surveys of our work. That article got the highest readership rates of any article in Consumer Reports history. More than any other car article, electronics article. 94% of women, our female readers, read that article. That's incredible. You know, women aren't as interested in cars and electronics and things like that. So we've been around for 76 years. We were founded by activists, socialists, radicals. Some of them were on McCarthy's list in the 50s. They basically believed that consumers would get a raw deal when it came to to markets that were influenced by advertising, because advertising would not be independent. And in fact, what I've learned to say to anyone who says, well, John, you know, you're doing a lot of damage by doing these comparisons. We really should wait to do these until we know a lot more about them. And I say, I'm happy to do that. Stop advertising. Because advertising are comparisons. Advertising, look at them. Virtually all of them say, well, we're the best. Well, they're comparing. You know, if a hospital is comfortable putting up a billboard or running TV commercials, then they better be comfortable with our comparisons. You know, what's good for the goose is good for the gander. My only financial relationships is with Consumer Reports. When I came, the best way for us to work at CR is I have no academic conflicts, which can be a very powerful conflict of interest. But I do have intellectual conflicts. I'm a primary care doctor, and I cannot shake that discipline. I practiced primary care medicine and practiced at the VA. I've moved around a lot for a variety of reasons. So this is my 13th job. I had 12 of them in Oregon. I get lots of input from consumer activists and from my team. I've been very fortunate to have many mentors, including Cheryl Gelman, who's in the back. You know, what I learned is you get an MPH from PSU, and Cheryl mentors you, and you get a job offer from Consumer Reports a few years later. But I was fortunate to work for Governor Kitzhaber. Dave Shaheen and Fred Edwards are two surgeons from the Society of Thoracic Surgeons who have taught me a lot about comparing doctors. Steve Weinberger, who's the Chief Executive Officer of the American College of Physicians, Daniel Wolfson, Chris Castle, and Wendy Levinson. Wendy was here in Oregon for a decade or 15 years. She's a former practice partner who's now on the board of the American Board of Internal Medicine. She's been an incredible mentor. Jim Guest, the CEO of Consumer Reports, and Cheryl. So we think conflicts of interest are a big deal. The American Medical Student Association is comparing conflict of interest policies for medical schools and academic medical centers. OHSU is kind of mediocre. I think they just went from a C+ to a B- or a B. ProPublica has published dollars for doctors. You can Google that, and you'll get right to a page where you can put in a doctor's name. So you could put in John Santa and then say that Santa's in Oregon or New York. And they'll look at a database of voluntary disclosures from 20-some pharma companies about who they've been giving money to for the last 2 or 3 years. The pharma folks are doing this voluntarily because the Affordable Care Act has a section in it called the Sunshine Act that mandates that they will publicly disclose money they're giving to doctors. And we're going to have that information in 2015. The ProPublica database probably only has 20% of the information about who's getting money. And so here's an example. Tony Montanaro is a terrific doctor. He took care of my patients. He's a good doctor. He's a good clinician. But he has very substantial financial relationships with many pharmaceutical companies. You could see this in about 30 seconds if you went to ProPublica's database. This is all public. It's all public. Okay? You have to decide. You know, I'm not trying to show this. At my reunion where I gave a talk, I showed it to a room like this of about 70 physicians and said, you better decide. In the future, if you work with drug companies, you're going to be on a slide like Tony is. And you better decide whether that's something you want. It's okay with me. It's just for consumers, consumers deserve to know what doctors are working for somebody else than them. That's all. It's not unethical for Tony to do this. But I think what's fair is for him to make sure his patients know, you know, I also work for drug companies. And here's what I do for them. This one does have something interesting in it. And that's that some of this money has gone through the OHSU faculty practice plan. And that raises a number of issues because the OHSU faculty practice plan is the fund that physicians at OHSU are paid for. And those dollars are, I think, eligible for PERS. They're eligible for PERS. So that means Oregon taxpayers are involved in the payout for Tony in terms of his retirement for many years that in part's been built around these dollars. So it's a big deal. It's a big deal. And I'm trying to be more overt about this to prepare all of you for, how are we going to deal with this when we find out that our doctors, or a significant portion of them, have relationships really that we deserve to know about. Well, consumer reports, as I mentioned, we do comparisons. We're raters. We're an iconic organization. We do comparisons. I mean, realize folks in a market hate comparisons. They would rather advertise. They would rather convince consumers we're the best based on advertisements, not on level playing field comparisons. Although folks in this room will tell you that if you are folks in this building, if you're a red meat eating capitalist, you want comparisons. You want buyers and sellers to be on a level playing field because you want price competition. That's what our country's supposed to be all about, is price competition. It's competition. It's messy. Some people lose. They lose money. They lose their reputations. This is what, we live in a messy country. And when industry dominates information, it's a problem. And it's one that Consumer Reports was designed to address. So this is how we see the current world for consumers. And we like the line, if I don't think it's going to work, will it still work? But actually, I've grown to realize the picture is more important. This is where the market is. This is the market, and it's not a level playing field. You've got a patient in an inferior position, the gown flapping in the breeze, the doctor erect, his white coat, projecting authority. Who's got all the information? Doctor's got all the information. We'll talk about that later, some interesting approaches to leveling that playing field. So we think part of our job in health is to try and level the playing field. And that's tough. We think it's very important, and especially, I think, a room like this. I hope nobody is naive enough in this room to think that the right thing is just going to happen. In fact, everybody can agree on the right thing. But I've been at this for, 35 years, been in lots of rooms where people say, okay, Santa, that's the right thing to do. But you're still going to have to take it from me. You're going to have to take the money from me. I'm not going to give it to you. I agree. That's the right thing to do. But sorry, I worked hard. I got some bill passed. I got some advantage. I'm not going to give that up. You're going to have to figure out how to take it. And when it comes to drugs, that's tough. You are fighting a huge industry. But it's tough when it comes to hospitals and doctors. Hospitals and doctors aren't going to volunteer to give up the position that they perceive they have fought long and hard for and that they deserve. So I'm sad to say that oftentimes this is how we perceive things for consumers now. Industry is a voracious, man-eating shark, seal-eating. And a lot of consumers are seals that are there for the picking. And it's our job to build cages around those seals so that the healthcare industry doesn't take advantage of them. You know, you realize, for example, in the pharmaceutical and device industry now, there's 28 companies, the largest pharmaceutical and device companies in the world. Almost all of them now have behavior control programs that they've agreed to do as part of lawsuits that the federal government has been successful with and taken huge amounts of money from them because of inappropriate marketing tactics. And then basically insisted that since we aren't going to put you in jail, you need to agree to a behavior improvement program. So really they're on the equivalent of parole, and they have a parole officer they check in with. Actually, Novartis was just sued 2 weeks ago because of allegations that despite the behavioral program you're on, you continue to give bribes. And that was the word the Department of Justice used. You are continuing to bribe physicians. We told you to stop, you agreed to stop, but yet there's still lots of evidence that you're trying to bribe physicians. So when I talk to consumers now, here's what I tell them to get their attention. And this is a surprise for most of them, by no means all. It's great that there's 100,000 plus folks in IHI, because those folks are trying to figure out the solution to the third most common cause of death in the United States. After heart disease and cancer, Peter Pronovost, this isn't Consumer Reports, Peter Pronovost, the country's premier expert on safety, thinks that if we had access to all the data, that unsafe, incorrect practices in the healthcare industry, especially in hospitals, would be the third leading cause of death in the United States. The third leading cause of death in the United States. Second, despite a commitment for this to all occur in a market economy, in fact, the Affordable Care Act is market-based. It's a market-based solution. Consumers and physicians have no idea what health services or products cost. How many of you read Steve Brill's piece in Time Magazine? Yeah, 28 pages. It's nauseating. Nauseating because that was happening 30 years ago. I mean, when I was at Blue Cross for 10 years, we caught hospitals doing incredible stuff. We could never get them to stop. The charge master's been around for 20, 30 years. And then with Choosing Wisely, a figure that is, I think, stunning to a lot of people. Most experts, Don Berwick, for example, from IHI, is out there saying every day he talks 30% of the current healthcare services are wasteful, duplicative, low value. So we really have a challenging system, which means there's a lot of opportunity for people like you all. There's an incredible opportunity for folks like you all. Now, we think the way to approach this is similar to what the Council of Medical Specialty Societies thinks should be done. 2 of their 3 priorities are listed here. Council of Medical Specialty Societies is the umbrella arm for physician associations in the country. So the American College of Physicians, the American Academy of Family Practice, all of those professional societies belong to CMSS. 1, we should stimulate, facilitate a culture of improvement in practice and in consumer understanding and participation. And in consumer understanding and participation. You know, we scratch our heads and think, well, now, how is it then, if consumers should understand and participate, that it was only in 2010 when we made hospital infection rates public that any federal agency agreed it was time to make hospital infection rates public. In fact, every federal agency opposed making hospital infection rates public until that time. They thought it should be kept a secret. the degree to which hospitals were experiencing infections that were preventable, that hospital processes and procedures were the cause of. Second, CMS says we need to support professionalism. We couldn't agree more. We'll talk about choosing wisely. That involves altruism, self-regulation, and transparency. So how are we going to get there? Well, let me share with you a few slides that gives you a sense of how you might look at the system in terms of figuring out where you might focus. Most of us end up focusing on the work of heroes and innovators, brilliant folks who have incredible ideas and take the system on and succeed because of their brilliance and their tenacity. It's terrific, and we're going to talk about some of those ideas. Oftentimes we realize what's going on because early adopters have said, okay, we'll do the right thing. Research shows whatever they're doing does work, and in one way or another, there's then incentives so mainstream folks come along and start to do it. But on almost any project, any effort, there's a substantial portion of folks who straggle along. You know, this is why the average time that it takes to do something everybody agrees is correct is 18 years. 18 years. I mean, we think, you know, the hero innovator stage is a year or two, and the early adopters are a couple years, and mainstream is 3-4 years. It's the stragglers that take 10 years. And so one interesting aspect is to focus on the stragglers. I mean, we can already tell you who the hospitals are in Oregon that are straggling in terms of hospital infections. They've had lots and lots of time to get their act together, and they haven't done it. How do you get those folks? Even, you know, mainstream rewards and incentives aren't working. How do you deal with the stragglers? And then, of course, there's the crooks. It is kind of surprising how much crookery there is going on in the country and not getting reported. And certainly, I think one of the contributions that Dr. Berwick made when he was the director of CMS was to bring much more visibility to that and to urge healthcare folks and consumers to be more aggressive around crooks. I was listening to a talk a week or two ago where a physician was saying one of the career regrets that she had is she practiced within a block or two of a Medicaid mill. She knew it. She knew they were doing terrible things. She never reported them. They eventually got found out because they were so greedy that the government figured it out. She could have reported them many years earlier and saved a lot for taxpayers and patients. Our approach involves a mix of confrontation and collaboration. I've talked to you about how important it is to start by being trustworthy, independent, transparent. But that doesn't mean you need to be nice. You know, you need to have confrontation skills. You need to call people out. You need to make them accountable. But then you also, I think, have to have a sense of, okay, when do I agree to step back from that? How can I help? How can we get you on the right track? One of the, I think, challenges if you're confrontational is if you break it, you need to fix it. I mean, Peter Pronovost made it possible for us to be aggressive around hospital infections because he fixed it. He showed you change the culture, you use these checklists, what happens? 0% infections in some cases. Dramatic reductions in infection rates in hospitals. So we could break that knowing there was a good fix. You develop a competence at tools, which we've done, and you'll see them. I've talked about comparisons, and we're also getting better at what I call overuse strategies. But as I mentioned, markets are really messy. They are especially messy when you want to tell consumers what not to do in health. That don't do what you do to tell them what to do. You know, if you had a cure for cancer, you could probably get millions of people to come to cureyourcancer.org pretty quickly. If your message is beware overuse of testing in cancer.org, not many people are going to come to that. So you've got to go where people are when you have a, you know, don't do this message. We were very proud, for example, in Choosing Wisely, that Vogue had a 2-page article on Choosing Wisely. Vogue. They even made their cover. I mean, Consumer Reports, we'd love to go wherever there's a bunch of people who read Vogue and, you know, tell them about the safety and consumer issues. You talk about what they're talking about, and then you move the conversation. You connect your dots to theirs, which is usually most easily done by safety. You know, believe me, we've seen this play out in focus groups where you're talking to someone about, let's say, CT scans and imaging, and you know, they'll say, well, you know, why should I object if my doctor wants to do a CT scan? And if you say, well, it costs a lot of money. Not me. I mean, I've got insurance, or yeah, I may have a co-payment or something, but it's $50. But if you say, well, do you realize that CT scan is the equivalent of 350 chest x-rays? That you're getting radiated to the tune of 350 chest x-rays? Believe me, in focus groups, they're going, okay, now I'm listening. Now I do want to know more about whether I really need this CT scan. You use empathic stories. In the cancer story I told you about earlier, we were so fortunate to get a doctor, an infectious disease doctor, who had 2 prostate screening tests for cancer. You all know what that is, a PSA, which the evidence is very poor that this works. A lot of us have been urging men to not get this test. So he gets it twice. The second one is a little bit higher than the first. His urologist says, well, to be safe, we should do a biopsy of your prostate. He says, well, okay. He gets a Pseudomonas infection, gets septic. It's in his bloodstream. He's in the hospital for 4 days and almost dies. So that was our lead story. That gets people's attention. But then when you tell somebody what not to do, you need to tell them what to do. Okay? And so in everything we're doing in Choosing Wisely and elsewhere, we not only tell them what to do, but what not to do. When we tell people, look, be worried about hospital infections, they're expecting us to say, well, so what can I do? Because I'm not sure I can get that hospital to do anything different, but what can I do to protect myself or my family from a hospital-acquired infection? Much of our work involves 2 broad strategies. We're becoming very good at doing large-scale, broad-topic, multimedia campaigns. So much of what I'm going to show you is that, Choosing Wisely, our ratings work. But then we're also trying to get better at more focused, specific population-oriented work that focuses on one disease or one situation, again, where these fixes are. So here's an example of Choosing Wisely. So we're the consumer partner in a program that identifies things that are overused. We produce documents like this. Here's examples. They're 2 pages. They're plain language now. We initially had our own journalists write them, and so we were up at first or second year of college. Now we're down in elementary school. We actually had an interesting argument at Consumer Reports because some of our journalists read these after the plain language and said, well, this is kind of demeaning to our readers. We think they'll be kind of insulted by this. No. What works for plain language works for everybody. And so these have been very successful. We actually have just finished a survey of a nationally representative sample of 2,669 consumers who received this information. 72% agreed that it had changed their opinion of the topic, taught them new information, or prompted them to ask more questions. 81% of consumers reporting interest in a topic. So they had back pain, or they had a family member who had back pain, said that they were likely to have a conversation with their physician about what they had read. And in the case of one topic, 85% intended to have a conversation with their doctor. And that's what Choosing Wisely is about, is stimulating conversations. This is a good example of going where they are. One of the great things we've learned is we work with Wikipedia. You all are familiar with Wikipedia, one of the 5 largest websites in the world. We have a Wikipedian in residence. Okay, there he is, Lane Raspberry. He's actually from Seattle. Great guy. He understands how Wikipedia works. So he takes topics. Now, you know, Wikipedia really doesn't want experts like me or journalists from Consumer Reports going in and inputting. They want people like you. So Lane has taken Choosing Wisely topics, and he's gone in and either taught folks from the professional society how to have input into their process, or he's done it, or he's trained other people, medical students and other folks, to do it. So there's now Choosing Wisely content on hundreds of Wikipedia pages. In fact, we estimate every quarter 10 million people are seeing Choosing Wisely content through Wikipedia. And so one thing that many of you should think about is learning more about Wikipedia and how it works. Just north of here, the Washington State Medical Association is a partner of ours in Choosing Wisely. By the way, the Oregon Medical Association just got a grant from the ABIM Foundation to do work to bring Choosing Wisely down to a physician level. So they're going to be doing something similar, hopefully. The Washington State work is very consumer oriented. Involves a lot of social media. So they're really stepping up to telling folks about overuse. So how can you stimulate a culture of improvement? And we think you can do that by comparisons. And the key to comparisons actually are 4 things. You got to actually have the right names of hospitals and doctors. You know, people tend to not trust you if you publish the names of the hospital in their area and you get the names wrong. Now, actually, that can be very difficult. One hospital that we were publishing their heart surgery information emailed me one morning and said, Dr. Santa, we've changed our Heart Institute name to this name. And I email back and say, okay, we'll change that. It'll take a day or 2. Hour later, she emails and says, actually, I got the name wrong. It's this name. And I go, okay, we'll change that one. The next morning, she emails and says, this is really embarrassing, but that one's not quite right either. So she changed the name 3 times in 24, they changed the name 3 times in 24 hours. It's much more difficult than you think. 900,000 doctors, 900,000 doctors. And there's 500 cars, 5,000 hospitals. We can do hospitals, we got hospitals. 900,000 doctors, and the name is difficult. Evaluating patient experience. You're used to reading user reviews. There's more scientific methods, survey, good, solid social science. Those methodologies are out there. We're using them especially for hospitals. Evaluating quality of care in a variety of different ways, especially safety. And then estimating cost. Those are the 4 things that consumers want. We've published inserts in Consumer Reports in 3 states. This is of Minnesota, about how their doctors compare. In this case, it was on diabetes and vascular disease. Remind me if we have a chance in the question and answer period to share what the results were. We're focusing, as I've mentioned, on hospital errors and safety. We're really hitting the hospitals hard. We are not collaborating with the hospitals when it comes to safety. And they know that, and you know, the hospitals who do well like it. And I'll give you some examples. As I mentioned, we're especially interested in focusing on the stragglers. We're also doing physician performance. I'm going to give you some examples, especially around heart surgery. And I just mentioned the work we did in Minnesota. So here are some Portland data. So this is Legacy. I just gave a talk at Legacy because of the reunion I was at, and I thought, gosh, they should see their data. And I showed all 5 hospitals. So I took the 3 smaller ones out and put Providence, St. Vincent's, and OHSU in here. So the top you see our safety score. It would take me an hour to explain our safety score, but there's multiple components, all related, we think, to safety. 100 is the highest you can get. The highest scoring hospital in the country is 74. The lowest is 11. The average is 49. I mean, you can see, other than OHSU, Portland's hospitals are, a bit above average. CLABSI is central line infections. Again, 5 is good, okay? 1 is bad. So 4 is okay. Actually, Legacy does have a couple hospitals that have 0 central line infections. I think Salmon Creek does, and I think Meridian Park does. They're smaller. They're smaller and not as complex, so it's a little easier. You can see in terms of readmission, they're not doing quite as well. That's a big problem nationally. You can see when it comes to communication about new drugs or discharge, they're really struggling. These are consumers themselves grading hospitals on how good their communication is. When it comes to imaging, they're doing better. What this is an interesting measure. This is a CMS measure of how often does a hospital do a CT scan of the chest or abdomen with and without contrast. So they do 2 studies rather than 1. It turns out that hardly ever is that necessary for a chest study. Hardly ever. Abdomen, it's a little bit more frequent, maybe 5%. Now, good news is that for chest CT, all of the hospitals in Portland have got that figured out. For abdominal, you can see OHSU is struggling with that compared to the others. What does this mean? These are 2 CT scans. So you're more likely to get the equivalent of 700 chest x-rays at OHSU rather than just 350. The next measure is a federal measure of complications. You can see the 2 legacy hospitals outperform the other 3. And then the final one is a patient experience and overall measure. Again, they're doing better there, except for Emmanuel, where they have some work to do. Now, this is interesting data on heart surgery groups in Oregon. So we were fortunate that the Society for Thoracic Surgeons released this data to us. Now, each group had to okay it. Okay, so this is voluntary release. There's 1,000 heart surgery groups across the country. So far, about 400 have released. The first year, only 200 released, and only 2 in Oregon, Eugene and Medford. The measures here is there's a composite, so an overall measure. Survival, how likely are you to survive coronary artery bypass graft surgery? How likely are you to avoid one of 5 major complications? How likely are the surgeons to give you the correct medicines before and after surgery? And then how likely are they to do the one surgery we know improves outcomes in bypass grafting, which is a left internal mammary artery implant? So that's 2010. So it's great, these 2 volunteered. What happened the next year? More Oregon programs volunteered. But Eugene disappeared. I wonder why. They've never reappeared. You'll see next year. They still didn't appear in 2012. Can't help but think, well, maybe they're not 3 stars any longer. So here you see in this year, all the programs are 2 stars. There's a couple of worrisome things. OHSU kind of has a high complication rate, don't they? 22% of people are having a major complication. Now, think about this. Would you want to know this? I'd want to know this. I mean, I don't think I'd want to go to some place where I was twice as likely to have a major complication. St. Vincent's is struggling to get the drugs right. I mean, come on. That shouldn't be that difficult. Well, it turns out it isn't. Because in 2012, St. Vincent's figures that out. They went to 92% doing it right. They actually got a 3-star rating from STS. And look at who else is 3 stars. For somebody who trained here since the mid-70s, it is incredible to me how good Kaiser has become. But I can share with you, in a lot of things that we see, Kaiser's at the top. They really are. I mean, they are a top-performing system now. I knew that was happening in the 90s when I was competing with them recruiting doctors. In the 80s, we got all the best doctors. In the 90s, Kaiser started to get as many as we did, and by the end of the 90s, they were getting almost all the good primary care doctors because they had an electronic record, because they were organized, because they had better quality of life, because they could already see better outcomes. So look here, in 2012, actually, OHSU was still a 1-star for complications, 2-star overall, but they're still struggling with that. Cost is a huge issue, terrible, as I mentioned, no transparency. You know, folks have these consumer-directed health plans, and you go, how can you have a consumer-directed health plan when nobody knows the cost of anything that they're supposedly directing? There are a bunch of folks developing transparency tools. We got information from a website called Healthcare Blue Book. It's a great website, healthcarebluebook.com. Basically founded by a physician who was outraged when he realized how much variation there was in cost. He has managed to put together a database of negotiated fees. So this isn't how much the hospitals charge. This is how much they're getting paid, or the physicians are getting paid. Look at how much variation there is. Look at the CBC is the easiest to understand. As low as $15, as high as $105. And now nobody can tell you whether you're going to get the 105 or 15. This is absolute roulette. What Jeff Rice would tell you is in every market, and that includes Portland, the variation in price is a factor of 5 for almost every procedure. So it's a huge problem. Now, there are some ways to address this. In Minnesota, we publish these ratings of physician groups. So this is physician groups. The first column that says quality is an 88-measure composite of quality. It includes patient experience, diabetes, vascular disease, high blood pressure, lots of stuff. Again, 4 is good, red is good in the consumer reports, symbols, and summaries. Then Health Partners, a nonprofit HMO, has developed a comprehensive cost measure for physicians, okay? So again, 4 is good. So Northwest Family Physicians is at the top. They have high quality and low cost. If you look at Park Nicollet, Alina, Aspen, Quello, high quality, but high cost, okay? So they don't get our little dot for good value. By the way, one of the tricky things in here is because of the work of some of Cheryl's friends and colleagues, Judith Hibbard, an Oregonian, and Shoshana Sofar, a New Yorker, we know that actually for consumers to get this, we have to tell them, we have to have that column on the right for good value. Because if we don't tell them this is where the value is, they think it's where the most expensive is. They will assume the best quality is the most expensive. So you have to explicitly tell them where the best value is. So professionalism. I'm going to run through these very quickly because I think some of you have seen these before. So choosing wisely comes out of physician organization. It's designed to focus on overuse of tests and procedures. It comes out of professionalism. You know, physicians are supposed to be professional. They're supposed to be self-regulating. They're supposed to do the right thing. They're supposed to be committed to all of these, including a just distribution of finite resources. I like to tell the story because I think choosing wise is an incredible accomplishment. When I ran Oregon's health policy agency, Janine Smith does that now, Office of Health Plan Policy and Research. Governor Kitzhaber says, you guys need to take 10 or 20 things off the prioritized list, and We're going to insure 25, 30,000 people, so go do that. And so the Health Services Commission does that. And we have a meeting to meet with the professional societies in Oregon to talk about the 2 or 3 topics that each of them has that we're going to stop paying for. And I can remember I'm at the OMA, and we have some cocktails beforehand, and a specialist comes up to me and he puts his arm around me and he says, "John, I want you and Dr. Kitzhaber to know that we have nothing but respect for you. You are both great doctors, and we think what you're doing is absolutely the right thing to do. But I want you to know when we go in that room, I'm going to tear you apart." I mean, the things that are on this list are useless, probably dangerous, but I'm going to say in there that you're going to kill people, and this is a really bad idea. But I want you to know that it's okay with us if you go ahead and do that, because you are doing the right thing. We just can't say that in public. Choosing wisely, these professional societies are finally stepping up and saying publicly, we're doing things that are wasteful, duplicative, that are not a just distribution of finite resources. At least we hope they're saying that. They're also saying that physicians need to be responsible for that. No more finger pointing. They need to be accountable, and to their credit, they seem to be doing that. Zeke Emanuel says physicians need to stop looking to others to find solutions. There are now 135 of these topics. They started out mostly as diagnostic tests, but they're all over the place now. 20 screening tests are wasteful. 31 diagnostic tests are wasteful. 11 tests done preoperatively. 28 treatments are wasteful. 12 tests done as a routine follow-up or monitoring. They're in all kinds of diseases. 21 topics say we're wasting resources when it comes to cancer. Imaging, 55 topics that involve waste and poor value, 19 of which are CT scans. 23 topics related to drugs. 8 of them are antibiotics. That's not a surprise. But a bunch of medicines that we've just worked so hard at trying to get people to stop overusing, antipsychotics, opioids. Now, the one I like is there's actually 5 drugs in Choosing Wisely that the drug companies are currently actively advertising. So they're driving demand for drugs that the doctors are saying are wasteful. At the top of the list is the testosterone drugs. Have you seen the ads for the testosterone gel? Have you seen the ad where realize there's no evidence that testosterone helps sexual function, okay? Helps with erections. This is not an erectile dysfunction drug. This is not Viagra. And yet if you look at the ads, it's not what the ads say. The FDA can regulate that. It's what they show. My favorite is an ad that, in the middle of the ad, as they get to complications, shows a very attractive looking couple. The guy is better looking than anybody I've ever put on testosterone. He gets up, the wife is kind of seems somewhat exhausted, laying in the bed. He gets up, sits on the side of the bed, and as they're talking about the complications, he goes like this. It's the image that counts, not what they say. There's now topics about women, about children. So really, Choosing Wisely is birth to death. Overuse is everywhere, in every specialty. And there's enormous opportunities, I think, for folks in communities like this one, especially in Oregon, where we've had a culture of accepting that there's lots of things going on here that we don't need. I mean, the prioritized list has been around for 20 years. It's time that folks used it on the commercial side to discourage things that don't work well. Very robust topics. Again, cancer, heart disease, millions of decisions are involved in these, tens of billions of dollars. Imaging is a huge problem. Let me tell you my favorite imaging anecdote. A pediatric interventional radiologist in the Midwest did a simple study. They could do it at Emmanuel or at Dornbecker. He took 200 consecutive children referred to the center who had imaging tests. Okay? And you know, these days they come with a CD. And so you can see all their images. Well, you can also see the dose of radiation that was used to generate that image. Okay? What percent of those images, those 200 children, do you think got a child dose? 10%. 90% of them got an adult dose. So basically, a lot of imaging facilities just, the machine's on an adult setting, they don't adjust it. So it's you know, diagnostic radiation, not treatment radiation. But realize in children, diagnostic radiation can have impacts 20, 30, 40. You know, me, I could get lots of CT scans and it might improve me. I don't know. But that's not going to be true for children. There is a program called Image Gently, which, to the credit of some radiologists, are trying to figure this out. Antibiotic overuse is a huge topic, and we're hoping that Choosing Wisely will help. Nice systematic review just out about the approaches that work, both persuasive and restrictive. Early elective delivery and induction, early elective induction, a huge issue, significant incidence. It's bad for babies. So, you know, I was sad to hear that idiot Kim Kardashian, who's pregnant, has been saying on the media that she's tired of being pregnant. And she's going to try to deliver as soon as she can. Well, the data is overwhelming that elective delivery before 39 weeks results in cerebral palsy, cognitive difficulties, and neonatal intensive care unit stays. It's bad for mothers. They're more likely to have C-sections and the complications, but it's profitable because more babies end up going to the neonatal intensive care unit. So, you know, especially in OB where there's so much concern about malpractice, what's going on here? It's solvable. Here's data from, about 10 Minnesota hospitals, all part of a chain, Allina Health. You can see the light blue column is 2009 baseline. Across the board, they've done something dramatic to get rid of elective deliveries. This is all about convenience for the doctor and the patient. It's not about good care, but it's very difficult to get rid of. ACOG first told obstetricians to stop doing this in 1977. 1977. Finally, let me close with the latest idea I think is really interesting. This comes out of Tom Dalbanco at Harvard and Jan Walker. It's called Open Notes. Patients are invited to review their doctor's visit notes through secure patient portals. Patients are told when there's a new note that they could review. They've piloted this in 3 places, Beth Israel, Geisinger, and Harborview. So, you know, just 4 hours north of here. 100 primary care doctors, 20,000 patients. 3 overall questions. Does it help patients become engaged? Does it drive the doctors nuts? And what happens once folks are used to it? Doctors had a lot of concerns. Concerns that their visits would be longer, they'd have to spend a lot more time and a lot more time writing. After the intervention, those concerns were not borne out for the most part. Patients reported taking better care of themselves, better understanding, and better memory for what they were supposed to do. 69 to 80% felt better prepared, 77 to 80% more in control, and if you're interested in medications, 60 to 78% said that they were doing better taking their medicines. This is interesting. After a year of experience, primary care doctors were asked, taking all this into account, would you like your patients to continue to be able to see your visit notes online? And as you can see, a significant percentage said no. But when offered the option of actually turning it off, not one doctor asked to do so. And the reason, after 1 year, almost 100% of patients wanted to continue this. And they said it would be a big factor in who they would choose. This is a no-brainer for consumers. This is a no-brainer. So we like this. We're getting involved in this, and one of the things I've started trying to do here in Oregon is to see if I can use my relationships to get the major systems to voluntarily move to open notes on June 13th. We have an invite-only meeting of the major systems to talk about open notes. Tom will come out. Jeff Selberg, who's the Chief Operating Officer of IHI, will be out. IHI loves this idea. You know, we would like to have some folks from We Can Do Better. If there's some folks from the IHI school who could attend. We don't have unlimited room, but you know, it would be good for some real people to be there. That makes all those folks a bit more honest. You know, this isn't without its risks. It actually, if you have Epic, is not expensive. They can turn this on now for free. And Epic is the dominant system in Portland. What costs money is if you want to restrict it. So you say, you know, if you want the doctor to be able to say, well, this patient, I don't want them to get it. That costs money. So my parting advice, as you think about what you're going to do tomorrow, next week, next month, next year, think about doing something for or with consumers. Choosing wisely was so powerful because ABIM Foundation and those associations did it with us at Consumer Reports. If you see some fraud or abuse, report it. It's a crime. Stop it. Try to get involved in something that actually harmonizes things in healthcare. The two-piecer that we did on maternity, we finally got two of the societies to do something together. The family practitioners and the obstetricians did a piece with us together. It took them 4 months to agree on the wording. It's really difficult to get doctors to agree on anything, but it's possible. Think about doing something that focuses on the stragglers. They're really, I think, a problem in terms of slowing things down. Talk to patients, talk to the public about things that aren't self-serving, and talk to each other. Because, you know, we're strong believers that when you're through learning, you're through. It's so great to be here. I went on way too long, but that's what Liz said it was okay.
Thank you very much, Dr. Santa. That was wonderful. Let me bring up the other slides. No slides, I guess. Yeah, that's fine. No problem. All right, so now I'm going to introduce Ms. Baxter. Liz is the Executive Director of We Can Do Better, an organization that believes in the power of leverage, that small groups of people can have great impact, and that even a small state like Oregon can influence the national debate on health and health care. Liz has spent her career building bridges between complex policy initiatives and the public's ability to understand these issues. Ms. Baxter spent 5 years with the Office of Oregon Health Policy and Research, overseeing a federally funded state planning grant looking for strategies to expand coverage to uninsured Oregonians. 12 years with Legacy Health System, working on connecting traditional medical care and community-based supportive services, and 8 years working with Medicaid and Oregon Project Independence in Washington, Multnomah, and Clackamas counties. She was most recently appointed in September of 2011 to chair the Oregon Health Insurance Exchange Board of Directors. Liz is also an alumna of the MPH Health Management and Policy track here at Portland State University. Thank you for being here.
So I was going to bring slides, but I didn't know until, I don't know, yesterday that I was supposed to speak. So I thought I was just responding. And the only slides I could come up with were pictures of my grandson wearing his We Can Do Better t-shirts. So what I would like to do is to just tell you a little bit about We Can Do Better, and then we can just launch into just a discussion with John. But I do want to just share this short story, which is that John is one of the reasons why I am working with We Can Do Better. And in the fall of 2005, I got to sit in a room with 3 men named John. John Santa, John Uelling, who at the time was the president of the Foundation for Medical Excellence, and John Kitzhaber. And then former Governor Kitzhaber had this idea. And it was really coming on the heels of both the 2000 and the 2004 presidential elections, where people were dissatisfied, they were disengaged, they were really pulling away from believing that our public policy and our government folks could actually do anything of substance and make it make sense. And he thought that launching a movement where you tried to re-engage people and have folks from the ground level and folks from the top actually working together to move change would make a difference. And so in January 2006, we launched the Archimedes movement and then since changed it to We Can Do Better. We're in our 8th year, and sometimes I feel like that was just yesterday, but it was 8 years ago. And we have shifted the focus. Oregon has been able to accomplish a lot, to do things in some bipartisan ways when other states have really struggled with doing that. And part of it has been working at the top and working at the ground. And so Dr. Santa was one of our keynote speakers at our conference in February. And after his session, I just started getting emails from folks about this notion of what could We Can Do Better do with choosing wisely. And our board a month ago actually decided that we wanted to formally partner with both Choosing Wisely and the Open Notes program to try and see how we could get to, it's not just them that have to do something, it's not just decision makers, but that there's always something that I can do differently as we're moving forward. And a number of things that were in your slides actually reminded me of one of my first conferences that I went to was down in California. And the head of kind of the parallel of the Oregon Medical Association in California was giving this talk. So this was, I don't know, a long time ago. But he said that in California, their estimate was that half of what physicians prescribed and half of the healthcare services actually had the desired effect, that they actually felt confidence that it was effective and the right thing to do. The problem was they didn't know which 50% it was that was making a difference. And so when I think of then and where we are now and having data to be able to drive how people make decisions and it's a stunning difference between then and now. So I have a couple of questions that I guess I'm going to start with, if you don't mind. I don't know if you're supposed to sit up there. You can go on stage. I don't know if I'm supposed to sit up there with you. I have no idea. You get to tell me what to do.
You're sitting up there.
Work? Yeah.
Yes, those are hot.
Sure. So one of the questions that we'll start with, and you've got some questions?
We got
All right.
questions coming. Sure.
Fantastic. But was whether the data and the, kind of the populations that you've looked at, if all of that holds true for communities of color and communities where there are significant disparities, whether those recommendations would be the same looking forward?
For our work in general?
I think it was, the question that came was around choosing wisely and just the recommendations of what the use and not use, the do and not do, whether those would be the same.
Yeah. A challenging question. We think overuse is common and is, as I mentioned, birth to death, all specialties, and we think it's in all populations. And we're looking at how to measure that, and it's difficult to measure because most of the Choosing Wisely topics are not never do this. They're in these situations, don't do it, but in these situations, it's reasonable. I can tell you one of the slides I didn't use this time is the consumer organizations that are involved in Choosing Wisely. My guess is this audience knows you always look to see who's involved, but you also look to see who isn't there. And there is no African American consumer organization that's working with Choosing Wisely. And part of it is they're very skeptical that they should be telling their audience not to ask for everything, because they have, of course, suffered repeated discrimination when it comes to health care. We've had the same challenge to some degree, a little less so with Hispanic populations. It's interesting, we are working with an organization that does education for migrant worker clinics all over the country. And so they have been putting Choosing Wisely content out there. And we've done some focus groups with them and their providers. And it's interesting, first of all, overuse is important to them, because as they say, we get migrant laborers who think they should be treated for antibiotics. They want to work. So they think that antibiotics are the thing to do, or that they need a test. So they're as vulnerable to all the ads, all the overuse as anybody else. And interestingly enough, they do recognize the Consumer Reports brand. And actually, they also struggled with some of our initial work because, as I mentioned, it was college level, and then it actually turned out we used a Spanish translator who made it even higher level Spanish. And that's an issue. You have to be careful that you don't convert plain language English to highly literate Spanish. So, no, that's a real dilemma. My sense is most of the populations you're referring to have traditionally been more concerned, as they should be, with underuse.
Question?
Sorry, I'm trying to get the light up your eyes. Okay. Great, so we have a question for the panel. How can we use the consumer-oriented approach to help all the players understand the health benefits of public health interventions? So this is
Well, first, what's the saying? 95% of success is showing up. You would be amazed how much a room changes when there's real people in it. When it's just industry folks, there's a completely different conversation tone. When there's real consumers, when there's buyers, and it's clearly, we're here because you're sellers, we're buyers, we want to be treated fairly. There's a completely different conversation. When somebody's there who asks, well, so really, what's the evidence for this? What's the evidence? Can you show me a high-quality systematic review that shows this works? You can train somebody to be fairly good at those kinds of questions pretty quickly. And oftentimes, folks who have experienced the healthcare system and then learned about it because they weren't happy with their experience can become very savvy consumers. And especially, one of the nice things about our audience is they are highly educated. I was giving a talk one day about our hospital ratings and referring to how we did something, and a fellow starts to ask me questions, and it's clear he understands our statistics better than I do, despite my MPH. Well, he's a retired applied physicist who worked for 30 years in the submarine plants in Groton, Connecticut. He knows his stuff. He knows statistics. And he is a really great consumer to put in the right place.
So, the part that I guess I would add is, I'm not sure that we think of ourselves as consumers when it comes to public health. And so how we get public health experts and public health supporters to be much more integrated in this conversation, I think is really important. And the work around the coordinated care organizations and how those governance bodies look, I think, is one opportunity. But in some ways, and this is somewhat counter to Consumer Reports, we struggle with the notion of, are people consumers? Is that the role that they play? Or is there some other terminology that would then cross those boundaries of the medical care and how we utilize that and how we utilize traditional public health services.
This next question is for Dr. Santa. Do the comparisons between hospitals in terms of complications take into account the complexity of patients? For example, does OHSU have more complex cardiac patients? Is that why they have higher complication rates? I know that more surgically complex patients are referred to OHSU.
Well, when it comes to the heart surgery ratings we publish, we actually don't do the risk adjustment. The heart surgeons do. So it's a risk adjustment methodology that Dave Sheehan and Fred Edwards, the two folks I referred to in my disclosure slide, have developed with the help of some of the most sophisticated statisticians. They've published it all. Everything they do, they publish in the annals of the Society of Thoracic Surgery. So it's transparent. Do all the surgeons agree that it's fair? No, but they work with it. I mean, actually, this is a good issue. People often say to me, well, John, you know, how is it that Consumer Reports is smart enough to do something that we all struggle with? And my answer is, we don't want to. We want you to. We want the healthcare providers, we want doctors especially, to develop the risk adjustment mechanisms. On our hospital data, we do the risk adjustment. For infections, we're fortunate to have the CDC now involved. And all that data goes to a national database called NHSN. They do the risk adjustment, and then we basically publish it. CMS does a lot of risk adjustment on some of the other issues we do. So it's all risk adjusted. Would everybody agree it's fair? I'm sure not, but it's risk adjusted.
Great, thank you. So the U.S. is one of only 2 developed nations where there's direct-to-consumer advertising is allowed for medications, prescription medications. Is there a movement in the U.S. to change this? Can we make this advertising illegal? Huh?
When you were describing the commercial, you know, I'm actually really curious if you know how they will always tell you that the volume on commercials goes up? I'm really curious if the volume goes down when they talk about complications. And I mean, I've just been, you know, there's just something in because I think if anybody listened all the way through those commercials, we would never take a drug. Everything is going to cause us to die, become suicidal, you know, everything that might have been wrong with us and dormant is going to go wrong when we take, but you know, we are a market consumer driven kind of a society, and I just think that if there's a way to make them more honest, you know, and I don't know if that ties to the transparency or any of those pieces, but it is that there is the things that they say, and then there's the subliminal messaging with what they are showing. And both of those, I think, should have to face the truth test. And right now, only what they say has to face the truth test.
Yeah, I think most people think it's a very heavy lift politically to imagine that direct-to-consumer will go away. I think there is more and more support from doctors that there be more controls, that there be more penalties. You know, I think a lot of groups would like for drug executives to go to jail. I mean, a lot of these lawsuits have revealed acts that if a doctor did them, they would and they are going to jail for them. But company executives have managed to avoid that. That would make a huge difference if an executive is put in jail. But it's a heavy lift.
This is also for both of you. Do you think the Choosing Wisely program would be effective if applied to a historically and medically underserved low-income population, i.e. the majority of those coming in under the Medicaid expansion? If not, how could other patient engagement strategies be adopted?
You know, I think it was this week that the article, the study was released about the Oregon Health Plan and utilization. I mean, I do think that we are under this belief that once someone gets coverage, the thing that they should do is access more care. We still have this common belief that more is better. And so, I mean, I think that the CCOs and people in the Oregon Health Plan are ripe for more information about what does it mean to get that coverage, and that more is not always better. I mean, I think that without that, we are going to see utilization rise, and I'm not sure if it's going to be good utilization, better for their health, more effective, but it will be more, because that's what we believe as a society, more is better. And I think that somehow choosing wisely is one of those opportunities to break that relationship.
And I think actually that people who have less coverage or no coverage are not as vulnerable to the choosing wisely topic. So much so that I'm waiting for a study that shows you're more likely to have bad outcomes the wealthier you are. You know, how many New Yorkers do we have? Is there anybody out there other than me that's familiar with New York? So what hospital do you think in New York City has the highest rates of elective delivery before 39 weeks? Lenox Hill. Lenox Hill serves the Upper East Side. It's where the wealthiest New Yorkers live. So in all likelihood, the worst maternity income or outcomes in New York are at Lenox Hill. You know, they serve the people who just want to have their baby when they want to have it. And when I look at choosing wisely, I think somebody could do a study and show that. The wealthier you are and the more demanding you are, the worse your outcomes are.
This next question is also for both of you. Most consumers are removed from decision making based on, you know, an employer chooses your health plan, the health plan then authorizes your treatment, so forth. So how can consumers pressure employers and health plans to purchase wisely on their behalf?
Say that again?
Try.
Yeah.
Okay, most consumers are removed from the decision-making, general decision-making of, I guess, who they're getting the care from, because it's all employer-based, you know, health insurance for the most part. And then health plans are authorizing or reauthorizing treatment and so forth. So how can consumers pressure employers and health plans to purchase wisely on their behalf?
Well, there are now companies who have transparency tools. Caslight is a venture capital, or is it private equity funded? Anyway, they've raised, I think, $250 million. They go to employers, they basically get all their claims, they have software that so you can go in as an employee, and let's say you're thinking about seeing a dermatologist. They will tell you, okay, here's how much it's going to cost if you go to the one you've chosen, but there's 3 others within a mile, and 2 of them are actually higher quality that will cost less. So one way is to promote transparency tools. Another way, albeit more controversial, is really coming out of Oregon, which is to have a value-based, evidence-based benefit design. So your cost sharing varies depending on how strong the evidence is that this works. So that the things that are being overused, you're going to be paying 50%, 100% for. The things that are being underused that are very effective, you're not going to be paying anything for. So rather than cost sharing being a blunt hammer, it becomes a more precise tool through benefit design. A third is you evaluate the physicians, like the folks in Minnesota are doing, on quality and cost. And you tell folks, overall, this group of physicians looks like it's a higher performing, higher value group. Go to them. And we'll pay more if you go to them, and we'll pay less if you go to somebody else.
So I was still trying to track the question, and to me it was a perfect example of how the question included an employee an employer who was purchasing health coverage for providers to get paid, and that question kind of had almost all of the pieces of the perfect storm that we had here. And so if I get to the end of the question, what is it that employees can pressure their employer to do? I'm not sure it's necessarily that they can pressure their employer which health plan to purchase and who those providers should be. But I do think employees can pressure their employers to say, whatever we want at the end of the day, we want it to cost less and we want to get to better health and we actually want to have the right things covered at the right time. And that might put pressure on an employer to actually approach what they do in those decisions differently. But for the most, I mean, unless it's perhaps a very small firm, most of us as employees not involved with the decision that our employer makes about what coverage to purchase. And if somebody had an idea of how that could happen, I'd love to hear it.
Right. Kind of tailing on that a little bit, this is for you, Liz. What role do you see the consumer advisory councils for the CCOs or other healthcare systems in advocating for more transparency, like we were talking about, from their own organizations? Will they be effective? How could they be improved?
Well, they could be improved if they were more public. That would be incredible. You know, the consumer advisory councils and their level of transparency vary from coordinated care organization to coordinated care organization. So we have 15 different experiments that are happening around the state. But they are the place that is supposed to be reflective of their community's values and what is important in their community. They're responsible for community health assessments and community health improvement plan. And I think that they have a lot of potential to shift the direction that an individual coordinated care organization, what the approach is that they might take. But I think we're going to have 15 answers to that. At least that's where it appears right now, because they have a lot of flexibility and a lot of local autonomy to do things that make sense for their community. I think that if every person in this room applied every time there was an opening for one of the community advisory councils, that would be amazing. There actually are community advisory councils in the state that have not met yet because they cannot form. And so use the ability and the knowledge that you have. I say that's one great opportunity to get involved.
Awesome. Thank you. So apparently I need to speak up a little bit. So the mic's not picking up my voice for whatever reason. So actually both of you, since you're talking about the Open Notes program and this new collaborative, I think as a group we'd be interested in hearing a little bit more about Open Notes, just in general, what you guys are going to be working on together.
Well, you know, I think what we're trying to do is figure out how can we help to get, first, the larger systems to adopt Open Notes, pilot it voluntarily. You know, will IHI's reputation help? Will Consumer Reports' reputation help? Will We Can Do Better reputation or brand help? How can we get those systems to you know, be the first to jump in the Open Notes water? Everybody agrees that I don't think you're going to see many doctors or health systems go public and say, we don't think patients should see their notes. You know, when you look at Tom's data, nobody's going to do that. But the cultural issues are significant. A lot of physicians are going to be worried that their documentation isn't up to par, that they've used language that some people will find insulting, that there will be adjustments that they will need to make, et cetera, et cetera. And getting past those cultural issues will be what's hard, and that's not going to occur likely in a very public way. But I think we can help as consumers. Consumer Reports can help by saying, look at this information. And look at even physicians who were wary. When they tried it, they figured it out. This can work out. And I think Oregon's perfect because we like to do things like that. And we're much more transparent. I mean, believe me, in New York, transparency is very difficult. There's an enormous amount that happens in healthcare in New York and New York City that nobody has any idea what's going on.
One of the reasons that it matches for We Can Do Better, you know, for 7 years, every day I have somebody calling me or asking me, what can I do? What can I do? And I think that what they're always hoping is that I can give them the phone number of some decision maker who's just been waiting to hear from them, and it's going to make the difference in whether a bill gets passed or, you know, some policy gets changed. And I think that it gives us the ability to say there are ways that you can actually begin to change behavior and culture without waiting for the governor to sign a bill or Congress to pass an act. And that so much of, you know, the patterns of usage are really about behavior. They're about what you learned when you were in medical school and, you know, how your practices evolve, and that it's one more way to put leverage on the system. And that, you know, if we're playing the role of patient, that we actually have the ability to make change. It will change my health or my mom's health or, you know, my kid's health, but it also might just change the way that provider interacts with the next patient. And so it gives us one more thing that people can do.
This is kind of a technical question. I know we are a lot of Epic users. So what's the difference between MyChart and OpenNotes?
Yeah, good question, because actually when we met with the Epic folks, their first reaction was, well, it's already there in MyChart. And actually, I'm a legacy patient. I've never transferred my care to anyone in New York. So I use MyChart. So MyChart has a lot of the output from the note. So it has lab, it has a variety of things. That's what I've mostly looked at is for lab. But it doesn't have the story. It doesn't have how is this physician thinking? What do they think of me? What actually did they, was their objective? What did they tell me to do? Again, sometimes those instructions will be there in MyChart, but sometimes they aren't. You know, many of the folks who were in Tom's pilot noticed the incorrect stuff in the notes. And so one of the most interesting parts of OpenNotes is, will it improve safety? So that, because the patient can read it and say, no, that's not right. I'm not on that medicine or not on that dose. So it's a completely different set of information, and it's more meaningful.
So are like hospital legal counsel, I mean, are they all over this? Are they concerned about liability, and is this coming up?
I'm sure it will. Yeah. My own sense is it should help liability, because basically anything that improves communication and trust reduces malpractice for physicians, anything. So ultimately I think malpractice will be a plus for OpenNotes. You know, I did risk management for Good Samaritan for several years, and then for my medical group, and then for a larger medical group. And you know, I think one of, the example I used to give physicians is actually the OMA in the men's restroom. I can't say this is true for the women's restroom, but in the men's restroom, in those days, they had, you know, those cloth towels that you pull on a circle? Well, in big letters in the towel thing was, don't put your head in the towel loop. You know, how could somebody be so stupid that they would put their head in the towel loop? Except probably somebody did and strangled themselves, you know. But I would tell doctors when we'd have these meetings at the OMA, you know, look at your records. Don't put your head in the towel loop. Don't say stupid things in the chart. It was amazing how a lot of physicians would just say stupid, unfeeling, insensitive, racist, chauvinist, sexist stuff. And it's in everybody's best interest to stop that. You know, so I think it's a positive in terms of malpractice. And I think we're actually going to approach some malpractice carriers because we think they'll agree. And they will encourage the adoption of OpenNotes.
So in the slides that you had, did the providers who took part in the open notes, did they feel like they actually changed what they were documenting?
Some of them, yeah. Yeah.
Another question here for you, Dr. Santa. Can you talk a bit more about your decision regarding not to collaborate, but rather target hospitals? Can you speak to that?
Yeah, well, most of that actually is driven by, we have an advocacy arm. It's called Consumers Union. And we have about 80 to 100 employees who are focused on advocacy causes of a variety of sorts, many of them health. So we've been involved in what's called the Safe Patient Project for over a decade. Consumer Reports, Consumer Union, was one of the major forces in state legislatures, including this one, to introduce legislation requiring the hospitals to publicly report. And eventually 28 states passed mandatory reporting of hospital infection logs. Through those activities, we've attracted thousands of patients who've been harmed by infections. You know, I think it's those folks' very strong feeling that as much as we love to err is human and crossing the quality chasm, it has not worked. Now it hasn't worked because the industry didn't do what those reports said to do. I mean, those reports actually said there should be public reporting. And there wasn't until it was mandated in the Affordable Care Act for hospital infection. And so our organization has felt like we need to, you know, rattle everybody's cage that those were wonderful reports, but they didn't work. Wonderful folks like Don Berwick. Folks have not paid attention to Don. Yes, some hospitals have, but all those stragglers haven't. They haven't. You know, yeah, the early adopters do. Kaiser has. You know, George Halverson sent out a letter to his employees, and there may be Kaiser employees here, that for the first time now there's Kaiser hospitals who have gone many months, maybe even a year, without a decubitus ulcer. That's incredible. That is incredible. So, no, some of them have done it, but most of them haven't. So.
Okay, another question for you. I appreciated the what to avoid when you're expecting report, but I wanted references. I guess that's a comment. Are all reports written at the same level, or do you have a system for identifying report topics that might benefit from more detailed reporting? And why not keep putting in references? Why not have the references in there?
Yeah, well, there's very rigorous fact checking, and so anyone who wants all of those, we will provide it. In print, we don't, because the real estate is limited. I mean, we talk about that a lot. In a magazine, there's just not enough real estate to do everything that you might want in one with the references. On the web there is, so we're more likely to put references, especially around methodology issues on the web. Usually in our work, like if you went to our site for hospital ratings, you would see like a 35-page document about all the methodologies we're using in terms of our ratings, and there would be references there.
That's helpful. Chad, do you have another question there? I see your paper. Yeah, I think we have time for one more.
When using open notes, how do you reconcile physicians writing objective findings about a patient with limited insight that are in the patient's best interest for providers to know, but which the patient may feel is inaccurate?
Yeah, that's a challenge. I mean, there's several challenges. One is mental health. I think we all agree that there are some situations in terms of mental health when someone could be harmed, that information needs to be restricted. I think there's also situations in which some language might offend a person either culturally or for other reasons. One of Tom's touching anecdotes is a person who reported in the survey that after the visit she went home and she read her note, and she was very upset that the physician described her as obese. She never thought of herself as obese, but she did meet the definition of obesity. And it really upset her, it bothered her, but ultimately she felt like she's taking her situation more seriously because she doesn't like being called obese. So I think a lot of those things are going to have to be worked through. I mean, you know, frankly, for an older person, I look at culturally a lot of the things we did 35 years ago, and you know, we've changed a lot, and we should have changed a lot. And you know, I've learned constantly in consumer audiences. I'm corrected constantly. Our advocates correct me constantly, and I apologize and I try to learn because I think they're oftentimes right, that I've used language that, you know, isn't fair or is biased or, you know, something of that sort. So, you know, for a doctor, hey, you have to get used to level playing field. People are going to give you feedback, and you know, it's going to hurt, and so you have to learn.
Wonderful. All right, go ahead.
So how does Consumer Reports pick the topics, the things that you're going to focus on?
Well, you know, the scientists are inputting. This is a topic we can do a comparison. In my case, it's I can get data from the outside. You know, like I can get data about heart surgery. Right now, I can't get data about joint replacement surgery. I can get data about drugs. I can't get data about devices. Because actually there isn't a common nomenclature about devices, so no database can be crosswalked because there's not a common, there's not a CPT or HCPCS coding system for devices like there is for drugs. So the science people have input, here's what we can study. The journalists, here's what we think our audience wants. Here's what we're interested in. You know, we're watching the media and watching, you know, what's going on. Our business people, of course, are saying, do you guys realize the readership rates that we got with this story or that story? And we can tell which pages precede somebody subscribing. So suffice it to say that the stories that result in a lot of subscriptions, the business people want to run. And at the other end of the spectrum, the advocacy folks want causes that they're interested in to be topics. So actually it's quite a menagerie with everybody saying, well, we're independent, you know, scientists are independent, journalists are independent, the business people want to make money. And so there was a lot of rooms filled with New Yorkers who yell at each other a lot and disagree. And we have social scientists too who do surveys and focus groups, and so they're saying what their surveys and focus groups are saying, and the only thing that saves us is we have a deadline. And so we got to do it.
Wonderful. Well, I want to thank both of you for taking the time to be a part of this tonight. It was wonderful.